So we did the partial knee talk, and now we're going to switch gears and move on to total knee. You've already seen a lot of the kind of canned slides that we have, but I'll try to put my unique perspective on it. And actually, I'm now mostly retired from clinical practice, and I'm doing this teaching and consulting thing on a regular basis because I really think it is the future. Once again, my disclosures. What we're really talking about here is improving knee arthroplasty. I mean, if it was a perfect procedure, there would be one implant system and one technique, and that would be the one. I think the most important thing you need to do is to pick the right procedure for the right patient, and that's what we talked earlier about partial knee versus total knee. I think you need to pick a great implant with a great track record. And for my money today and for the last 10 years, that's been the triathlon knee. I was a fairly major Zimmer consultant for about 7 years. And when I switched to the triathlon, I immediately saw some benefits to my patients. I think you should use the most tissue and patient-friendly approach, muscle and bone sparing with good pain relief. And for my dollar, that still remains an MIS procedure, and that's only enhanced by the aid of robotics. And finally, I think you should use the most accurate cutting technology available. For 25 years, I did it with hand tools. Then I moved on to navigation for about 10 years, and most recently with robotics. So today I would combine MIS and robotic arm arthroplasty for either partial or total knee. So you might ask yourself, what's wrong with total knee? And I think the problem is what we're measuring. I think we're looking at the wrong end point. For years, 30 years, the number one question you would get asked when you talk to someone about a new knee procedure is, well, what are your 20-year results? We've solely been focused on how long does the knee stay in the body and using revision as an endpoint. And while that's important, I won't deny it, that's really not how the patients measure success. They want to know that it feels good, that it functions well, that it bends well, that it feels like their normal knee. And I think just using revision as an endpoint grossly estimates pain or poor function. Price et al. Did a 12-year study, and they found that if you use revision at the end as the endpoint, 82% were still intact. But if you look at moderate or severe pain, really only 59% were considered to be successful. And depending on various studies, you look at anywhere from 7 to 20% of total knees have a poor outcome due to just dissatisfaction. I'm not happy with it. It hurts. It's stiff. It doesn't feel good. Feels like a block of wood. In fact, somewhere around 6% of patients at 6 months say their knee is worse than it was when they started. And I think we, as a group of surgeons, need to do better. So total knees suffer from what I like to call the 20-20 problem. 20% of people are unhappy with it, but they're stuck with it for 20 years. It's like going out and spending $1,000 on a brand new set of Pirelli tires, and you take them out on the freeway and they go thump, 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 and you're unhappy with them, but you can't afford to turn them in. I think some of that is an inability to both plan and execute appropriately, but I think part of it is because of the compromises in implant positioning we've made based on two-dimensional x-rays. We look at an AP view and a lateral view, and in our minds we try to construct something in the middle, and that doesn't always match with what the knee wants, what it feels. And concurrently, then 1 in 5 patients are not happy. Part of that's an implant problem. And on the left, you see the multiple radius J-curve construct that we were all trained with back in the 80s and 90s, and that was based on simple lateral x-rays. And the way you do that, you bend the knee 90 degrees, you set it on a film, and you shoot an x-ray beam, and you get a picture like on the left, and it looks kind of egg-shaped, and that's a multiple radius. Well, some really smart people got together with the advent of MRI in the early 90s, and they realized that when we do a total knee, we actually want to have that parallel and rotating parallel to the transepicondylar axis. And when you do that, when you tilt the gantry on the machine so that you're parallel or perpendicular to the transepicondylar axis, actually the back part of the knee is a circle. It's a single radius design. And the Scorpio knee and then the triathlon knee have been based on that design. Here's a diagram of that. On the left center there, you can see the axis of the beam is perpendicular to the transverse axis of the knee, and that gives you the multiple J-curve, but at the bottom, if you tilt so that you're perpendicular to the transepicondylar axis, then you have the single radius design. And for my patients, that has made a big difference in how their knee functions, and in particular, their mid-flexion instability that Dr. Rajgopal was referring to earlier. The other problem is one of execution. There's a lot of optical illusion in the knee. If you have a great big fat knee with a real skinny bone inside, what I like to call the bird bone in a balloon, we see it a lot, particularly with female patients. It's very hard to see what's actually going on. It turns out that all of us in the room have physical limitation. Our eyes are roughly 3 to 4 inches apart. We stand a foot or two from the knee. And so our eyes can only detect 3 degrees of malalignment. As you saw in earlier talks today, the margin for error is roughly 3 degrees. So actually our margin for error is just about 0. And so consequently we have problems executing within the limits of the system. So because of that, in about 30%, somewhere as large as 40% of conventional surgeries, and even up to 10% of computer-assisted surgeries are put in incorrectly in malalignment. The dirty little secret is we can't do it well with hand tools, but it's the best we've had up until very recently. Also, there's potential adverse events. You can cut the MCL, you can cut the PCL, you can cut the popliteal artery. There's 2 kinds of surgeons in knee replacement surgery: those who have cut the popliteal artery and those who haven't cut it yet. And as you saw earlier, the number 2 cause of revision failure of total knee, particularly early failure, is instability. So I showed you earlier that we've had great success with partial knee replacement, and with that we went on to move into the total knee world. We found that basically in my studies and a number of others that we're about 3 times better with the robot than we are with hand tools. Improved alignment, improved balancing, and improved cutting accuracy. And now if we get improved implant fit with the CT-based guidance, and we get improved function with the single radius, I feel this will lead to improved long-term satisfaction. So enter robotic assisted arthroplasty. This is a surgeon interactive arm. It's CT-based, and I think critically 3D information. For the first time, we get a really good look at the flexion gap, the femoral rotation, the tibial rotation, and how that interacts in a dynamic way. This allows us to use computer-assisted planning, balancing, and cutting, computer-enhanced protection, and of course, as you've seen, we have applications for partial knee, and total hip, and most importantly, we're able to get reproducible and consistent results. This is my personal data, my first 67 robotic partial knees, and my last 67 hand-instrumented partial knees. And why 67? We picked a 3-month period. I took every partial knee that I did, including my very first case. We collected them, and then we collected the same number retrospectively of hand tools. Basically, this is error. And the error in the orange bars is error with hand tools, and with blue bars is error with a robot. Basically, the error is 3 times higher with hand tools, even though these were theoretically the best partial knees that I ever did. Again, taking this to our registry data, dramatically better with the robot than with the hand tools. And I showed you this one before earlier. Revisions much lower with the robotic partial knee, and I feel that we can take this now with great confidence on into the total knee world. This is a marketing piece, what Stryker has to say about partial knee.
Our knees are the largest joints in our bodies. They're central to almost everything we do. So if you or a loved one is suffering from arthritis or an injury to the knee, everyday activities such as walking, sitting, or kneeling can feel debilitating. But you're not alone. It's one of the nation's most common causes of disability and impacts the lives of 54 million people in the United States alone. One possible treatment option for knee pain is total knee replacement, a procedure that involves removing the damaged bone and cartilage, then replacing the knee joint with an implant to reduce pain and restore the motion and function of the knee. Today, knee replacement surgeries are being combined with a new technology, and it's changing the way knee pain sufferers are treated. Meet Mako, a robotic arm-assisted technology used by surgeons to perform total knee replacements. This unique technology helps surgeons provide a personalized surgical experience, where each surgical plan is based on a patient-specific diagnosis and anatomy. And in a laboratory study, Mako Total Knee enabled surgeons to execute their plans more accurately, while also protecting soft tissue and ligaments from damage. Let's take a look at how it works. It begins with a CT scan of the knee joint. A CT scan is a series of X-rays taken at different angles that can help surgeons see things that they can't typically see with an X-ray alone. The CT scan data is used to generate a 3D virtual model of the patient's unique anatomy. This virtual model is loaded into the Mako system software and is used to create the personalized preoperative plan. Prior to surgery, the surgeon reviews the plan size and placement of the implant, and if necessary, modifies the preoperative plan in order to better position the implant to the patient's unique anatomy. During surgery, the surgeon locates points on the knee in order to register the anatomy in the Mako system. This process establishes the relationship between the patient's actual anatomy in the operating room and the 3D model that was used during the planning process. This step helps ensure the procedure is executed to plan. Once the anatomy is registered to the 3D model, the surgeon has the flexibility to modify the preoperative plan based on their assessment of the patient's anatomy and range of motion. Then, the surgeon guides the robotic arm to remove the arthritic bone and cartilage from the knee. A virtual boundary provides tactile resistance to prevent the surgeon from removing more than just the arthritic bone identified in the preoperative plan. And visual cues, shown in green, appear on screen to show how much bone to remove. Collectively, these cues help the surgeon stay on the preoperative surgical plan. With the diseased bone gone, a knee implant is inserted into the joint space. And once the surgeon is comfortable with the knee's movement, it's off to the recovery room to begin the journey towards strengthening the knee joint.
I think that has some valuable information. Again, with the total knee, the workflow is very similar. Across the top line, we have the preoperative steps where we get the CT, segmentation, it's made into the plan. Then we open the joint. Importantly, we tension or kinematically balance the, dynamically balance the knee. We make adjustments to the plan as needed, and also any ligament releases or balancing you might need to do. And then finally, we do the bone prep. This is from the original IDE software. And again, you can see it's very similar to the Uni. We have the CT view, AP on the left, ladder on the right, and in the middle, importantly, we have this 3D reconstruction. And we've set up the software so that you can either use it as a bone resection, measuring from the bone, which is what you're used to with a measured resection technique, or you can actually put cartilage on the knee, because we're ultimately trying to restore the knee cartilage surface, and do it as if we're doing a cartilage replacement, which is my preferred technique. Once again, my approach, I won't show you that again. Registration is the same. We just follow the bouncing ball, and this matches the virtual and the physical map so that the computer knows exactly where the bone is located. This is the saw. This is a special saw that we designed for use with the Mako system, and if you look carefully, you'll notice there's no cutting blocks, there's no rods, there's no jigs. There's basically 2 trays of instruments for the robot, and then you have your trials for the implant. So greatly, people talk a lot about cost, but we greatly reduced the cost of instrument washing, cleanup, and turnover in the room. And this saw is especially designed to work with the robot. So for the first time, we actually have perfect saw control. We have a computer-guided cutting path that offers protection of the soft tissues. We have this advanced software for pre-planning based on the 3-dimensional anatomy rather than 2D. And this allows, in my opinion, the most important thing of the whole system is this micro adjustment of component position. Some smart guy, probably an Indian mathematician, did the math and figured out there's 6 million possible combinations for a total knee. And I don't know how we ever got it right with hand tools at all, to be honest with you. But this enables us now to use complex cutting shapes, such as protecting the PCL island for a CR knee, and more complex surface profiles. We have a bicruciate spring knee in the pipeline. For those of you that haven't seen it yet, this is what it looks like. This is doing the anterior cut. And you literally pull the trigger, the virtual cutting block comes into play. The arm actually locks into the proper position and moves itself there, and then you just follow the dotted lines. You then move on to do the individual cuts. This is the posterior cut, and this haptic window protects the ACL and PCL complex so that you don't cut that with the saw. And I'm going to let this run just a little bit here because I want you to see the next part. Sometimes getting in this posterior is a little difficult. One thing you'll notice looking at the video, there's no assistant. Because of the need to see the camera continuously, we have self-retaining retractors, and basically it's a surgeon, someone kind of reaches in to suction a little bit and stuff, but watch how the arm moves it by itself, locks into place, and then you go. So one of the only change we made to the robot from partial knee to total knee was we had to add an assembly inside called the forklift assembly that moves and controls that arm to allow it to self-align into the joint. Once the femur's done, we move on to the tibia. And again, notice no cutting rods, blocks, no rods, no jigs. On the uni, we have an irrigation system here. There is none. So you simply cut the bone, you use the saw, and the cuts have been exceedingly accurate. This was, I think, case number 5 for me, so it's now actually more than 5 years old. This allows you to do simple primary total knee. On the left, you can see my preferred implant, which is the MIS Minikeel version with cement. But the cuts have frankly been so accurate and so good with this that I've gone to using mostly cementless knees now, what you see on the right. And these things, it just almost suction fit to the bone. They're extremely well fixed. So how does it work? You know, it's new. We've been doing this with the commercial version for about 3 years now. These are some early studies. This is cadaveric study, 12 specimens, 6 with the robot, 6 with hand tools. And by the way, the robot cases were done by junior residents. The hand tool cases were done by senior surgeons. And you can see the error bars on the right. The purple ones there are for the robot, less than 1 degree in every case. The hand tools done by the senior surgeons all over the place. So a junior resident with the robot is better than a senior surgeon with hand tools. Very frustrating for me personally. How about repeatability? This is from Art Mokani and Bill Hozak from Rothman Institute. 54 consecutive robotic total knees. This is determining how accurate is it for sizing. Long story short, on the femur, 96% were the exact size and 100% were within one size up or down. Tibia, it's a little less accurate, about 90% were the exact size. And basically the difference there is because on the tibial side often there are large osteophytes and you're not quite sure how much of that's going to come off when you do your pre-plan. But long story short, you're virtually 100% sure you'll be within one size when you walk in the door. How about soft tissue injury? Interesting study done by this gentleman comparing 30 robotic knees with 30 manually instrumented knees. Statistically significant differences in soft tissue injury with the robot, none, versus 10 out of 30, 30% with hand tools on the medial side, 7 out of 30 on the lateral side. So the robotic tissue protection, the haptics works, is a very safe procedure, is much safer than hand tools, even in experienced hands. How about stability? We've talked a lot about alignment and stability, and again, this is Bob Marchand, 473 knees, quite a large study. You can see on the right the wide range of alignments he started with, and he put them in the middle. Almost all of them he tried to put at 0, but there is a percentage that do better at 2 or 3 degrees of varus, or maybe 1 or 2 degrees of valgus for valgus knee. But importantly, 100% of his preoperative plans, he was able to adjust within 1 millimeter medial and lateral balance in both flexion and extension, 100%. So the balancing works. And satisfaction, that's a big question we started off this talk with, right? How good is this? And that's really hard to get a handle on, but it's very subjective. The main verified, validated study device for that is the WOMAC score, which is an arthritis pain and function score. And long story short, at 6 months, 20 knees versus 20 knees of robotic manual, statistically significantly better, lower pain with the robot, statistically significantly better overall score, and just shy of statistical significance, better physical function. And this is personally what I've experienced in my practice. Patients are just happier. Not to say that every patient is happy, but we have fewer complaints, quicker recovery, less swelling. I believe this is a less traumatic way to do the knee. You don't do a lot of flexing, extending, pulling things out. It's just less traumatic for the patient, and that allows them to recover more quickly. One of the common questions I get, well, what kind of cases can you do? Well, it's a total knee. You can do total knee cases. I wouldn't start with a really hard one. Start with an easy one until you learn the system. Actually, on the left, you see my first Mako total knee with triathlon. I had done already 20-some with the Mako knee before. It was a severe valgus flex knee. Because of the extreme side-to-side imbalance, I end up using a constrained TS-type implant, which you see in the center. On the right, you can see what I like to call a hybrid. It's a robotic manual hybrid. So I did the distal, all the femoral cuts, and the proximal tibial cut with a robot. And then because of the pre-op planning, I was able to see there was a very large medial defect, and I knew that I was going to need more of an augment. So I simply got the revision blocks, did a step cut, put an augment and a stem. And if you look carefully on that far right, you can see the medial side looks a little strange. I also, speaking to the soft tissue balancing comments earlier, I agree. I did a medial epicondylar osteotomy to slide the MCL distally and allow balance, and then used a constrained implant to protect that. The patient was up walking and went home in 24 hours. This is that very first patient, the valgus knee, 6 weeks post-op, great flexion. You can see it's a PS. That's my preferred method. You can do either way. I've done both. I just found ultimately I had a little quicker recovery with the PS knees. What about hardware? What about really hard cases? Well, this patient had this big rod, cerclage wires, broken screws. To take all that stuff out would be a nightmare. So we did our preoperative plan. I was planning to do a PS, but as you can see on the far right there, that box was coming dangerously close to the rod, and I was concerned about impingement, or maybe if I would have to, proximize the femur a little bit, I might have some impingement with the rod. Okay, no problem. I'll just do a CR. So we went ahead, did the CR. We knew about this because of our preoperative plan. It's a simple switch of a button on the computer, and we ended up with a very great functioning knee, a very quick operation. It took about 40 minutes, and the patient went home the next day. What about really hard cases? You can. Does it make the case easy? No. Hard cases are still hard. It's still a total knee. You do the same cuts you would normally do. The difference is you have more information. So you know what the ligament balance is going to be. You know how big that lateral tibial defect is. You know where the osteophytes are. You can see them, and it gives you a more powerful tool to work with. This is that patient post-op. Because of the gross mismatch side-to-side in ligament balance, unable to get it perfectly balanced. I knew that going in, so I had this constrained implant ready. We made the cuts. We did not need any sort of an augment. Because of the TS-type implant, I used a stubby stem on the tibia. And with the triathlon, one of the really nice features is if you're doing a constrained implant, you do not have to use a femoral stem. You can if you feel the need, but you don't have to. Well, what do you say about it? At 6 months out, the patient said, I believe in the robot. This is a kind of a tubby, fat lady. I was taught in my training that fat patients can't bend their knee. Well, it's because we cut the knee too much. And this is a CR knee, 6 months out. Patient's very happy with the result. This is now one of the original IDE patients, 3 years post-op, CR knee, great flexion. And those patients are now 5 years out. To my knowledge, no major issues or revisions. This was actually my patient, the very first patient in the world done with the Mako robot with total knee. It was Mako implant, CR type. He sent me this 6 months after surgery just to tell me how happy he was with this knee. And you see great strength, great quad function going up and then also down the stairs. So in summary, great implant designs and techniques allow you to be muscle, ligament, or bone sparing, and 3D CT visualization allows accurate planning of implants, pre-planning of joint balance, and perfect surgical execution of the plan. Victor Hugo said an invasion of armies can be easily evicted, but not an idea whose time has come. And I think it's time that we take computers and robotics and apply that to orthopedic surgery. Thank you.